we're going to talk about hematology, immunodeficiency, and throw in a little HIV. So this set of slides comes from, as you can see, Nursing 110 MedSurg 2. However, the same material is covered in Nursing 122 as a refresher. So I'm going to use the same slides. Here's an overview of the structures and functions. Hematology is the study of blood and blood-forming tissues, and those are bone marrow, blood, spleen, lymph system, and the liver. A basic knowledge of hematology is useful in clinical setting to help you to evaluate the patient's ability to transport oxygen and carbon dioxide, maintain intravascular volume, coagulate blood, and combat infections. Assessment of the hematologic system is based on the patient's health history, a physical examination, and results of diagnostic studies. Remember, we're using our nursing process, and we take all of this and pull this together. And then just some FYI, the spleen is made up of white pulp, which is filled with white blood cells, and a major site of antibody production. And the spleen is one of my favorite organs. It filters whole blood. It removes bacteria and old red blood cells. The red pulp part of the spleen stores red blood cells and platelets. And then there's a part called the marginal pulp, and that contains ends of blood vessels. So to sum up, the spleen destroys old imperfect red blood cells. It breaks down hemoglobin released from these cells. It stores platelets, and it filters antigens. Without the spleen, and you can live without a spleen, of course, many people do, but without the spleen, you have a reduced immune function and an increased, that scared me, risk for infections. Now, the lymphatic system helps rid the body of toxins, wastes, and unwanted materials. The fluid in the lymphatic system contains infection-fighting white blood cells throughout the body. The liver, of course, produces prothrombin and other clotting factors, and it aids in formation of vitamin K in the intestines, and that produces clotting factors 7, 9, and 10. And then also the liver is storage for whole blood and blood cells and extra iron, which is termed ferritin. The structures and functions, you have your bone marrow. There's two types of bone marrow, red, which is hematopoietic, and then yellow is adipose. What do I want to tell you about that? The red marrow produces blood cells in the adults. Cell-producing marrow is found in flat bones and irregular bones, such as your sternum, skull, pelvic, and shoulder girdles, and the ends of long bones. Red cells regress after birth, and then with aging, it ends up being there's more of the adipose tissue than there is the red marrow as we get older. And there's only a small portion of the bone marrow that in older adults that still produces blood. So you can see everything just starts slowing down because you're aging. And then hematopoiesis. I have on here hematopoiesis since the Iggy textbook is set up in concepts. Sometimes you have to look for stuff all over that book. It's not in systems like we're used to. So hematopoiesis was on page 1005 in the musculoskeletal system of the Iggy book. It occurs within the bone marrow, and bone marrow produces red blood cells, of course you know that, white blood cells, and platelets. These three types of cells develop from non-differentiated immature blood cells in the bone marrow. They call them stem cells. There's just a little overview here. The process of cell differentiation is poorly understood. However, stem cells seem to be able to develop into any kind of cell. So, for example, stem cells can differentiate into white cells, red cells, platelets, whatever they want. They just do. It's cool. It's a miracle. Researchers hope to someday use stem cells to help people with spinal cord injuries, Alzheimer's disease, Parkinson's disease, diabetes, etc. A whole slew of things. They are hoping that stem cells will replace destroyed or damaged cells. And then erythropoiesis is the selective growth of red blood cell production. And it is regulated by cellular oxygen requirements and general metabolic activity. Hypoxia stimulates the release of erythropoietin, which is a glycoprotein growth factor, and that's released primarily from the kidneys, which in turn stimulates the bone marrow to increase erythrocyte production. So the bottom line is erythropoiesis is stimulated by tissue hypoxia and controlled by erythropoietin. So I have a note on here that says many essential nutrients are necessary for erythropoiesis, including protein, iron, which is an essential part of the hemoglobin, folate from folic acid, cobalamin, which is vitamin B12, riboflavin is vitamin B2, pyroxidine is B6, pantothenic acid, which is and niacin, ascorbic acid, vitamin E. Then I have on here that B12 and folic acid influence production of red blood cells. Erythrocyte production is also affected by endocrine hormones such as thyroxine, corticosteroids, and testosterone. Hemolysis removes abnormal, defective, damaged, and old red blood cells from circulation through destruction by monocytes and macrophages, which normally occur in the bone marrow, liver, and spleen. So when the spleen removes damaged or aged cells, it does it via phagocytic cells, and the byproduct is iron and amino acids, and those are recycled. So because of the components of the red blood cell is bilirubin, hemolysis of these cells results in increased bilirubin to be processed by the body. When hemolysis occurs normally, the liver conjugates and excretes all bilirubin that's released. So sometimes that doesn't function very well when babies are first born, and they'll be a little jaundiced. My son was, and although he's a little jaundiced even as a grown man, his body does not take care of the destroyed red blood cells quick enough. So his bilirubin, he's always got a little tint of yellow in his sclera. Anyway, when he was born, they had me put him in the window and let the sunlight absorb that bilirubin. So blood. I love this slide right here. I love it because it shows you all the components of the blood. So it's a special organ because it's fluid. And there are two major components to blood. You have plasma and, of course, blood cells. You know that about 45% of the blood is composed of red cells, white cells, and platelets, and the other 55% is plasma. And remember, we talked earlier about plasma containing proteins such as albumin, and it maintains osmotic pressure of blood. It also has globulins and fibrinogen. So globulins is the transport of substances like iron, lipids, vitamins, and antibodies, and fibrinogen aids in the clotting process. There's also electrolytes, gases, nutrients, and waste. The term serum refers to plasma without its clotting factors. Most plasma proteins are produced by the liver, except for antibodies, such as immunoglobulins, and those are produced by plasma cells. Blood, we just said that, makes up about 45%. Blood cells do. So here's a big picture to show you. It's like a blast out of it. So remember, you have erythrocytes, leukocytes, and thrombocytes. Structures and functions. Well, red blood cells are flexible cells with very thin membranes, which enable them to pass through tiny passages, such as capillaries, and to facilitate the diffusion of gases. Erythrocytes are primarily composed of hemoglobin, as we've said before, and hemoglobin is a complex protein iron compound composed of heme and iron, and globin is a simple protein, a large molecule that functions to bind oxygen and carbon dioxide. As red blood cells circulate through the capillaries surrounding the alveoli within the lung, oxygen attaches to the iron on the hemoglobin. Oxyhemoglobin, which is O2 plus iron, is responsible for giving arterial blood its bright red appearance. And then as red blood cells flow to the body tissues, oxygen detaches or disassociates or unloads from the hemoglobin and diffuses from the capillary into tissue cells. You can read all about that on page 512. Carbon dioxide diffuses from the tissue cells back into the capillary, attaches to the globulin portion of the hemoglobin, and then that is transported to the lung for removal. Don't you think the body's miraculous? Every time I read these things or talk about these things, every class, I am in awe at what our human body can do. It's incredible. Lastly here, hemoglobin acts as a buffer and plays a role in maintaining the acid-base balance. This is just a nice little slide showing you natural killer cells, eosinophils, B lymphocytes, all those things that you learned in anatomy. I just like to see them every now and then. All that's coming out of that bone marrow matrix. And then this too, I don't go into really a lot of the immune system, not too deeply, but I do have this little slide up here to show you the different types of leukocytes and their functions. For my notes, I wrote leukocytes appear white when separated from blood. They are the body's defense system against infection and disease. Like red blood cells, they are made by stem cells in the bone marrow, and they have widely variable lifespans from hours to years. There are 5 different types of leukocytes, each with different functions. The granulocytes have granules in their cytoplasm and are called polymorphonuclear leukocytes. The primary function of granulocytes is phagocytosis, a process by which white blood cells ingest or engulf any unwanted organism, and then they digest and kill it. Neutrophils is the most common type of granulocyte, the primary phagocytic cell involved in the acute inflammatory process, and it accounts for 50 to 70% of all white blood cells. Eosinophils have a similar but reduced ability for phagocytosis, and they account for 2 to 4% of a white blood cell. So, when you get a CBC with differential, this is what you're getting. Basophils contain chemical mediators such as heparin and histamine, and thus are a part of the allergic and inflammatory reactions. They make up less than 2%. You can see where if somebody gets stung by a bee or something, and all of that histamine goes there to take care of that, a person's face will be huge because it's so vascular anyway. Agranulocytes have one discrete nucleus and no granules in their cytoplasm. Agranulocytes, A means without. Lymphocytes are one of the agranular leukocytes and contain 20 to 40% of white blood cells. Leukocytes include B cells and T cells, and from the basis of the cellular and humoral immune system, CD4 plus T cells is attacked and hijacked during HIV/AIDS infection. Most transiently circulate in the blood, and they also reside in lymphoid tissues. The natural killer cells are lymphocytes that do not require prior exposure to an antigen to kill virus-infected cells, and they activate T cells and phagocytes, and so forth. Okay. Thrombocytes are platelets. The primary function of a thrombocyte is to initiate the clotting process by producing initial platelet plug. Once they do that, in the early phases of the clotting process, after vascular injury, platelets are activated in the bloodstream and they head toward the injured site. Platelets must be available in sufficient numbers in blood circulation and must be structurally and metabolically sound for blood clotting to occur. Stem cells undergo differentiation by transforming into megakaryocytes, which fragment into platelets. Platelet production is partly regulated by thrombopoietin, a growth factor that acts as bone marrow to stimulate platelet production. It's produced in the liver, kidneys, smooth muscle, and bone marrow. And platelets have an average lifespan of about 8 to 11 days, and they are stored in the spleen. Oh, we're going to talk about anemia. And anemia will be something that we'll discuss together when we're all together. So be sure you read up on anemia, and you can tell the difference between the different anemias we're going to talk about. All anemias have some of the same basic signs and symptoms, but there's just a little piece here and there that makes them distinct. So what is anemia? It's decreased reduction or production of the red blood cell or hemoglobin, or an increase in the loss of red blood cells due to bleeding or destruction. So declining production of erythrocytes, deficiency of more of required nutrients. These are the things that could cause you to have that. Impaired bone function, impaired renal function, destruction or loss of erythrocytes, hemorrhage, genetic defects, immune reactions, toxins, infections, or a combination. Some causes of anemia. Now remember, anemia itself is not a disease. It is a sign. It's a side effect. Something else is wrong that's causing you to have anemia. So some common etiologies: there's iron deficiency anemia, vitamin B12 deficiency, folic acid, aplastic, sickle cell. Here's this glucose 6-phosphate dehydrogenase, and immunohemolytic anemias. I'm not going to concentrate on all of these anemias. For one, you'll have sickle cell when you get your peds and OB. I believe these others, you will probably talk about those there as well. So I'm mostly concerned with iron deficiency, B12, folic acid, aplastic, and that's pretty much it. Okay, here is the life cycle of red blood cell. I really like this PowerPoint slide because it shows you'll have a low blood oxygen. It tells the kidney something's up, and the kidney sends out erythropoietin, which tells the bone marrow you're going to have to produce some more red blood cells because we're not getting enough oxygen where it needs to be. And then this shows all the nutrients and such that the bone marrow needs in order to make those, and on and on. So I have production, circulation, and death of red blood cells. Every anemia is caused by one of three problems. Either it's a production problem, a production failure, a hemorrhage, or hemolysis, which is destruction. We just said that. The normal life of a red blood cell is about 120 days. Okay. Then I just explained, you know what a hemorrhage is, and then hemolysis, destruction. So you could have an infection which caused destruction of the red blood cells, or tumors, or autoimmune disorders. Some medications can do it. Leukemia can do it, etc. And then I think that's it for that. Clinical manifestations. These are the common ones for any kind of anemia. So you're going to be pale. Cool, your skin is cool to the touch. Intolerance of cold temperatures. Nails brittle, concave over time. Look at cardiovascular tachycardia. Why would you have tachycardia? Well, if you don't have enough red blood cells in your system, you've got to get the ones that you do have to all the areas that are screaming for them. And so your heart beats that much faster trying to circulate that blood quicker. Murmurs and gallops. Let's see if I put anything extra on that. It can cause that. Here we go. Murmurs and gallops heard on auscultation when anemia is severe. Then you can have increased, you can have fainting, you can have, and this all makes sense too. It's not like a low volume really, but yet you don't have enough cells. It depends too on why you have your anemia. You can have dyspnea on exertion because, again, there's not enough red blood cells to carry the oxygen into all the tissues. And when you start doing something now, demand outweighs supply. And decreased O2 levels, and then somnolence and fatigue. And then headache. I have nursing assessment. Of course, we get a history, get our vital signs, do a physical. We complete the health history and the physical history. Assess the fatigue. We look, well, they get a good old head to toe. Look at their skin and their hair, mucous membranes. What's their temperature? How's their skin feel? What's their turgor like? Peripheral veins, etc. Look at this gal down here. She is, I do have some of this on here because you can see that darker skin, sometimes you can't see paleness as well as you do on lighter skin. So when you pull the eyelid down, you can look in there at the bottom of the eyelid and see that it is much paler. And then this pictures of this gal right here, quite a difference. So what do we do for diagnostic testing? Well, we take a complete blood count, and that gives us our red cells, indices, and we would get it with a differential. Indices include average blood cell size, which is MCV, the hemoglobin amount per red blood cell, that's MCH, the amount of hemoglobin relative to the site of the cell, that's your hemoglobin concentration. You don't have to memorize all these. That's MCHC. It is interesting to note them because then when you get your CBC with differential, you'll kind of have an idea what they're talking about. What else do I want to tell you about this? This is just all of those, like MCHC gives you this. My notes here are just telling me that the normals for it. So complete blood count, we might do a hemoglobin erythropoiesis, and let me see if I wrote anything about that. Hemoglobin erythropoiesis. It looks for the different types of hemoglobin in your blood, and it's helpful in diagnosing the type of anemia. You know that ferritin is a protein found inside cells that stores iron so your body can use it later. So a ferritin test indirectly measures the amount of iron in your blood and is the confirming test for iron deficient anemia. Ferritin. The reticulocyte's an immature erythrocyte, and it can develop into mature red blood cells within 48 hours of release into the circulation. Oh my gosh. That scared me. Sorry about that. Anyway, when they do the reticulocyte count, if you have a bunch of immature red blood cells, then that's an indicator that things aren't going right. They have to figure out what that's causing. It says it is useful means of evaluating the rate and adequacy of erythrocyte production. And then serum iron is a test that measures how much iron is in your blood. And then there's total iron binding capacity, etc. Yes, I think we're good with this. A lot of info. You know, finally they can do a bone marrow biopsy, but that was absolutely the last thing they're going to do. Those things used to be anyway, pretty painful. But that's a definitive test. And it's also a test for a lot of things, you know, because of your bone marrow. If it's damaged, you're not going to be making your cells because that's where they're formed. And this comes straight out of your book, just some additional labs that can be evaluated. It's got iron deficiency. There's the B12, folic acid lab. Look, aplastic anemia. Everything you could ever want is right there. So, definition of the classification. This is just a slide that's got everything on there. And Khan Academy. This is a great video. So you might want to watch that. Maybe we'll watch it when we talk. I don't know. I'll see. Okay, here are classifications of anemia by morphology, and that's how it's shaped. I don't expect you to memorize this, but it's really kind of neat to know. So it shows you that if you have a normocytic cell, which is a normal-sized cell, you can have it in aplastic anemia. You can have it when you have acute blood loss, hemolytic, but it shows you also that when you get your lab values, you're going to show that you have a normal MCV, but you're going to have a decreased hemoglobin and hematocrit. My arrows are a little off. Then microcytic and homochromic means, micro means small cell, hypochromic means low color. So it's a pale cell. Small and reduced amount of hemoglobin, so it'll look pale. Remember, the hemoglobin gives it the color? And that is, in examples of that is iron deficiency. So this shows that all of these, MCV, MCH, hemoglobin, hematocrit, are all low. So then we have macrocytic or normochromic, so it's got the normal red color, but it's a big cell. Thickness and volume, and that's folic acid and B12. And then your MCV is raised, your MCH is normal, and your hemoglobin and hematocrit is down. It's just kind of interesting to put that in the back of your mind for when you do see blood work. So I put the CBC with differential in here, and I don't think I'll go through all of these MCV, etc., etc. You may know all that anyway. And then I just matched it. I just wanted you to see when you get a CBC with diff, what you got. Okay, so iron deficiency anemia is the most common type of anemia in the entire world, especially among women from menstruation, pregnancy, menopause. Older adults can have anemia because of decreased red blood cell production, like we just talked about. Their marrow, is being less red and more yellow, more adipose. Lack of appetite, they might not eat well. Chronic disease like COPD. If you're going to breathe or eat, you're going to breathe, not eat. Alzheimer's, where they get to a point where they don't care what they eat. They don't even care about eating. Iron deficiency anemia, short IDA, the pathophysiology. I've got that all listed here. I think that I'll just leave that there for your reading pleasure and read you what my notes say. Many substances are needed to form hemoglobin and red blood cells, including iron, vitamin B12, folic acid, etc. A lack of any of these substances can lead to anemia. The result is unmet tissue oxygen needs. I think we went through that. Any adult with IDA should be evaluated for abnormal bleeding, especially from the GI tract. So, my dad drank alcohol for years. He smoked cigarettes, I think, from the age of 9, so like 70 years. And he maybe didn't drink that long, but quite a history of alcohol. And we're talking every day here. And then he also has rheumatoid arthritis, so he aches. And he took Celebrex for at least 20 years. Well, he wasn't feeling very good, and he was pale, but they didn't think much about it. He finally gets in to see his family doctor. They draw blood, get blood on him, and probably they drew blood 1 week and he came back the next. You know how that works. Anyway, his hemoglobin was 3.4. I said, how could you be alive, Dad, with 3.4? You know what they did? They did not get an ambulance and say, they told him to go to the hospital. He drove himself. And umpteen pints of blood later, but they found out that for him, he was slowly seeping blood from the effects of alcohol and that Celebrex on his gut. So older people should not have iron deficiency anemia. They really shouldn't. And if you find somebody who does, or this says any adult, you want to definitely check for some sort of GI bleed, because that's usually what it is. Dietary intake of iron below the minimum requirements. So people who are at risk for that, of course, are adolescents. They don't eat very well. Women who are pregnant, you have extra nutrition that's needed. If you have low socioeconomic status and you can't buy the food you need, and non-Caucasian Americans are most at risk. Chronic blood loss from bleeding ulcer, hemorrhoids, cancer, or excessive menstrual flow. Continuous blood loss leads to less iron available to be recycled. And then if you have impaired duodenal absorption of iron, malabsorption syndrome from bariatric surgery, partial gastrectomy, damage to the intestines, prolonged use of antibiotics, celiac disease, Crohn's disease, cystic fibrosis, radiation, and some drugs. And then the rapid metabolic activity caused by pregnancy, adolescence, and infection can also lead to iron deficiency anemia, as well as severe liver disease from alcohol, because that suppresses erythropoiesis. If you've got low B12, which also comes from alcohol abuse, and that affects iron storage and production. And remember, if you have some of the gastric bypasses, you have to have B12 injections, and you run the risk of being low on B12. Oh my God, another yawn, folks. I better quit. I think I've beat you to death with insufficient iron equals decreased production of hemoglobin, which equals the decreased ability of the red blood cell to transport oxygen to tissues. You know all that. Iron is stored in the liver, spleen, and the bone marrow. Okay. So we got iron deficiency anemia. Now here's your clinical manifestations. And like I said, anemia is going to make no matter what kind of anemia, there are similar. And just go back to that first slide with the general signs and symptoms. But something extra on here is look at those spoon-shaped nails. That's from iron deficiency anemia. And look at the mouth fissures. That's from iron deficiency anemia. So even though you may have pale skin and pale mucous membranes and be tired and cold and irritable no matter what kind you have, you should not have spoon-shaped nails unless you have iron deficiency or mouth fissures. So medical management, we're going to, it says except for cases associated with pregnancy, you need to be investigated. Look what it says on here. If you're going to give it in an oral preparation, it is nasty. So you need to mix it with something, and vitamin C, give with orange juice or vitamin C supplements as the first line of therapy. Make sure you use a straw if you're giving it liquid, even if you mix it, because it can stain teeth, it can stain clothes, it can stain hands. It absorbs best on an empty stomach, but my goodness, sometimes that's very, very hard on a person. So they may have to eat a little bit of something. But would you give them milk? Absolutely not. That would just slow down the absorption, and no antacids either. That slows the absorption down. So absorbs best on an empty stomach. They may need to eat a little bit though. So the smallest amount of food as possible. Use a straw. Take with vitamin C because it facilitates absorption. If you're going to give it, it's kind of dangerous IV. They do give it IV, and I've been told that they have better solutions now so that it's not as dangerous for causing anaphylactic shock. To give it IM, you want to use the Z-Track method so you don't stain your skin. What else have I got up here? Oh, they want you to give a small test dose if you're going to give it IV or IM to make sure, and have epinephrine on hand just in case. Hemoglobin increases within a few weeks. The anemia is corrected in a few months. It's no quick fix. It takes much longer to replenish iron stores. So for diet, we want it to be rich in dark green leafy veggies, beets, dried beans, red meat, organ meat, egg yolks, and raisins. Iron in the diet is the easiest and the very best method for prevention. Oh yes, it causes constipation. You know, they wanted me to take that when I was pregnant, and I couldn't do it. It was too constipating. It made me sick. Stools will be darker. So look at these poor old people. They don't have much of an appetite anyway. They don't eat fiber foods. They're losing they're caring about thirst. Then they get anemic. We give them iron. Now they're constipated. Then you got to dig their stool out. I mean, it's terrible. It's terrible. Okay, let's see. Which signs and symptoms does the nurse expect to find in clients with any type of anemia? So what do we say? How about exercise intolerance, fatigue, and tachycardia? That's with any kind of anemia, nothing specific. So now we're on to B12 anemia. B12 anemia is going to have the same clinical manifestations regardless of how you have it. But remember, there are a couple of types. You can have B12 anemia because of dietary, which is really not very common. Sometimes people that are vegans have a little trouble with it, but there's supplements out there. Let's see. I have, in addition to older adults, other groups at high risk for developing a vitamin B12 deficiency are individuals with a history of disorders that affect the absorption of B12. So that includes gastrointestinal resections, like we said, some gastric bypasses. You can have autoimmune disorders, including AIDS, alcoholism, Crohn's disease, celiac disease, and a long-term use of medications that decrease gastric acid secretion, such as proton pump inhibitors or H2 blockers. So anybody who's ever been put on a proton pump inhibitor, it's hard to ever get off of them. I've tried and tried and tried. I can't get off of them. So this is telling me that puts me at risk for low B12. So does diabetes. So what I want to tell you is there's two ways to have B12 deficiency: through the diet or lack of intrinsic factor. If you don't have intrinsic factor in the gut, you cannot absorb vitamin B12. So you will be deficient in vitamin B12 and you will have the same signs and symptoms as somebody who's deficient in B12 through food. And then that causes other trouble. You see right here that B12 is a coenzyme with the DNA synthesis of red blood cells and the myelin sheath in the nervous system. Now remember, the myelin sheath covers those nerves. And when I used to teach my diabetes education class, a lot of people get this tingling, nummy kind of feeling, pin pricking kind of feeling, and that's from constant hyperglycemia, and that causes that myelin sheath to peel back. So the same thing happens when you don't have enough B12 for the DNA synthesis. That myelin sheath can become dysfunctional. So here is a video on pernicious anemia to explain the intrinsic factor and how that can cause you to have anemia because you don't have intrinsic factor to allow absorption of B12. Vitamin B12 anemia. So here's your clinical manifestations, and you'll notice that a lot of them are exactly like we just said about the other anemias. Some difference is glossitis, and glossitis is when your tongue is swollen and inflamed. It often looks shiny. You know how we have those normal little bumpy papillae, I think they're called. Well, you'll see here with glossitis, they don't really seem to have that. Let's see. They also have paresthesia, which is abnormal sensations. This is what makes B12 different from other anemias, because remember, B12 takes care of the myelin sheath, so it can cause neurological problems. So you have paresthesia, which is abnormal sensations in the feet, hands, and you can have poor balance for those with pernicious anemia. Severe B12 deficiency causes demyelination. It can lead to spinal cord degeneration, peripheral neuropathy, and altered mental status. And it's linked to depression. A lot of people that have diabetes have B12 deficiency, and a lot of them are depressed. Visual disturbances may occur as a result of nerve atrophy in the eyes. Abnormal cells they'll be large, so they're macrocytic, and it's called a macrocytic anemia. Management, because of the slow progression of vitamin B12 deficiency and delayed clinical manifestations, results of a CBC might be the very first indication that a person has that they do have B12. Now, of course, if somebody comes to the doctor with diabetes or some other indicator to the doc that makes him think, wonder if they might have a B12 deficiency. They would run that then, but if they didn't, then when they pulled your CBC, they'd have an indication then. On further investigations, need to determine the cause. The diagnosis of B12 deficiency is made based on history, physical exam, and the person will need to take people with pernicious anemia. Remember, that is the anemia where you don't have the intrinsic factor in your intestines, so therefore you cannot absorb B12 no matter what. So those people will have to have B12 injections for the rest of their life. It usually starts weekly at first and then monthly on from there. Nursing management. Teach the patient to increase the intake of food, such as animal proteins, fish, eggs, nuts, dairy products, dried beans, citrus fruit, leafy green vegetables. If they have a severe dietary deficiency, they might need supplements. Generally, though, you can replace, like we said, unless it's severe, with just changing your food. And getting anything through food is always the best. I just took a swig of apple ginger seltzer water. Is it sparkling water? Well, it sucks. It's not really very good at all. But you know what? I paid for it, so I'm going to drink it because I'm stubborn. Let's see. What else do I have on my notes here? And I believe these PowerPoints, I'm going to give you my PowerPoints so you'll have my notes too. But this is just in case you're listening somewhere while you're washing the dishes. Maybe you're doing laundry. Those who have pernicious anemia need to monitor hot and cold, for example, bath water, due to the decreased sensation, which paresthesia, and they also may need a gait assessment. Alrighty. Folic acid deficiency. Folic acid, which is vitamin B9, symptoms are similar to B12 deficiency. However, nervous system functions remain normal. Folic acid does not affect nerve functions, nor does it cause paresthesia. This is a slow-developing disease. Poor nutrition, a diet lacking in green leafy vegetables, liver, yeast, citrus fruits, liver. Dried beans and nuts are most common cause. So if you don't have a diet that includes some of these foods or all of these foods, that's the most common cause. Malabsorption from diseases such as Crohn's disease, because remember they affect the guts, are second most common cause. Drugs such as anticonvulsants and oral contraceptives can also contribute to folic acid deficiency anemia. Folic acid is needed for the formation of heme, the pigmented iron-containing portion of the hemoglobin in the red blood cells, which are called erythrocytes, but you know that. Management. Identify adults at risk and prevent the deficiency. High-risk adults include older, debilitated patients with alcoholism, patients at risk for malnutrition, those with increased folic acid requirements, such as pregnancy, because you know they give you that now. If you don't have enough folic acid, it can cause fetal neural tube deformities. And then folks that have sickle cell disease, which is, and a diet rich in foods containing folic acid and vitamin B12, like good old spinach. Have a Popeye meal. Citrus fruits such as orange juice, beans, bread, cereals, rice, pasta is good. Stop overcooking foods, because you'll cook that B12 right out, that folic acid right out. B9. Patients take a scheduled folic acid replacement for therapy. Okay. Here's aplastic anemia. So aplastic anemia is a reduction in oxygen transport in the blood due to impaired bone marrow function. Oh, now what happens when the bone marrow doesn't work? Well, what's the bone marrow make? All the cells. So when you have aplastic anemia, sorry, I had to cough. All your cells are at risk. So a reduction in oxygen transport in the blood due to impaired bone marrow function, which leads to a loss of stem cells and pancytopenia, which means a deficiency in all the cells. decreased number of erythrocytes, leukocytes, and platelets, all of those cells that come out of the bone marrow. Decrease or damage to stem cells, damage to microenvironment within the bone marrow, and replacement of bone marrow with fat. Evidence suggests cytotoxic T cells produce a substance inhibiting hematopoiesis, which is the making of new blood cells and platelets, causing a fatty, hypocellular bone marrow, that yellow stuff we talked about earlier. And that causes severe anemia. You'll have neutropenia. Anytime you hear the word penia, remember, guys, that means less than. So a decreased neutrophils is neutropenia, and thrombocytopenia is decreased platelets. Mayo Clinic causes for aplastic. Mayo Clinic, I'm having the hardest time reading this stuff. Causes for aplastic anemia can be radiation and chemotherapy treatments. While these cancer-fighting therapies kill cancer cells, they can also damage healthy cells, including stem cells in the bone marrow. Aplastic anemia can be a temporary side effect of these treatments, and exposure to toxic chemicals such as pesticides, insecticides can also cause aplastic anemia, and especially exposure to benzene, which is an ingredient in gasoline, has also been linked to aplastic anemia. The type of anemia may get better on its own if you avoid repeated exposure to the chemicals that caused your initial illness. Use of drugs, some medications such as those used to treat rheumatoid arthritis, oh no, and some antibiotics can also cause aplastic anemia. That makes sense because they're messing with the immune system, trying to keep that reaction down, and then that could further hurt your cells. Autoimmune disorders in which your immune system begins attacking healthy cells may involve stem cells in the bone marrow, and an example of that is lupus. A viral infection that affects bone marrow can play a role in the development of aplastic anemia in some people, and viruses that have been linked to the development of aplastic anemia include hepatitis, Epstein-Barr, the cytomegalovirus, parvovirus, B19 is what this says, B19, and HIV. For pregnancy, aplastic anemia can occur in pregnancy. It may be treated. Oh boy, it may be related to an autoimmune problem. For example, your own immune system may attack the bone marrow during pregnancy. And it can be a hereditary form. Fanconi's anemia is very rare. We don't know why this happens. In many cases, doctors aren't able to identify the cause of aplastic anemia. It's often called idiopathic aplastic anemia. Remember, idiopathic means we don't know. Okay, and then I have a little video here from John Hopkins on aplastic anemia. We might look at those when we're chatting. Here's some more about aplastic anemia. General manifestations of anemia, the same thing you would have for everything. I have fatigue, shortness of breath, decreased activity. Leukopenia, which is the decreased number of white blood cells, is a complication from bone marrow failure. It can occur before a person is diagnosed. And then the thrombocytopenia, you can have bruising, which is a late sign. So the onset can be rapid or slow. You're still going to have the same signs and symptoms of anemia, but if you don't have enough white cells now, you're at higher risk for infection. You don't have enough red cells, you're going to feel like you can't breathe. Enough platelets, you're going to have petechiae, hemorrhages, bruising, etc. So how do we manage aplastic anemia? Well, blood transfusions for transient or drug-induced aplastic anemia and the discontinuation of the offending drug, of course. Blood transfusions are only when the disorder is life-threatening. And it gives an example of bleeding due to low platelets. So, you can't stop the bleeding because you don't have enough platelets. They may do the transfusion. If it's transient, we want to discontinue the treatment we're doing once the bone marrow begins to produce red blood cells again. And bone marrow stimulants is Epigen. Procrit is another name for that. Neupogen. Immunosuppressants would be steroid therapy, prednisone, anti-myocyte globulin, ATG, cyclosporin, etc. That's on page 816 if you'd like to read up on that. You may need a splenectomy if the spleen is destroying normal red blood cells or suppressing their development. Hematopoietic stem cell transplant with donor cells is the most successful treatment for aplastic anemia, and it would only be used on that type, people who have aplastic anemia and nothing else is working. Might hit you that. So for nursing management, careful assessment for infection and bleeding, as well as rash or anaphylaxis during immunosuppressant infusions. You want to have avoidance of substances that could increase bleeding risks, so like aspirins or NSAIDs or alcohol. And then people with acute infections, for example, cold, or we want to avoid people that have acute infections, because our immune system, if we have aplastic anemia, will be lowered. And here is a case study. So maybe we'll do that together. Also, I have on this for concept mapping for each type of anemia, and that's a good thing too. I think we'll probably have time for that, and I'll see if I can't put together a concept map. I'll write myself a little note, concept map. Concept map for anemia. I like anemia. I mean, I don't want to have it or anything, but I like to talk about it. Let's see what else we got coming up here. Now, here's Polycythemia and Thrombocytopenia. These are clotting disorders. So we'll start first with Polycythemia. Polycythemia is a condition in which there's increased production of red erythrocytes or red blood cells. So polycythemia, too many red blood cells. Poly is too many. Your blood is hyperviscous, which means it's thicker than normal blood. Then you can have also Polycythemia Vera. That's primary polycythemia. This is a myeloproliferative neoplasm. In other words, this is, if you have Polycythemia Vera, that is a blood cancer. I do have a friend who developed this, but let me finish with this slide and I'll see if her story will fit in here. Let's see here. A disorder of the bone marrow causing low serum erythropoietin, which is a hormone, is causing the low levels of that. And then the myeloproliferative neoplasm are blood cancers that occur when the body makes too many white or red blood cells or platelets. The overproduction of blood cells in the bone marrow can create problems for blood flow and can lead to various symptoms. It's incurable. Lifespan is around 2 years if you have no treatment, and 10 to 15 years with treatment. So I will tell about my friend. So primary polycythemia vera is the blood cancer, and it's incurable, and they have to go be bloodlet. And this will probably show up here later as we talk. But anyway, my friend is 67. I think she's 7 years older than me. She's either 67 or 69. And 2 years ago, she's a travel nurse, and she's an ED nurse, and she's been an ED nurse for 100,000 years. So she's good at it. So a couple of years ago, she went to, I think it was Arizona, and it was in the mountains of Arizona, to like an Indian reservation. She was going to work in one of the hospitals up there. Well, she drives, and she was ascending, and just went to work, and just got sicker and sicker and sicker to the point where she couldn't even go to work. And she told them, I can't fulfill my contract. I've got to go home. I don't know what's the matter with me. She makes it back to Indiana. And then her daughter finds her like she's had a stroke. She can't speak. She's all crumpled up on the floor. They take her to the hospital, and they discover that she has Polycythemia Vera. Now, did she always have this, and that altitude change was the problem? I think so, I guess so, but nobody knows for sure. She said there's no one else in her family that she knows of ever that has had this blood disorder. But I'm telling you, she's had a hard row to hoe since then. Of course, they did bloodletting. They wanted her to take cancer chemotherapy because, see, that suppresses your bone marrow and your immune system. And the thought was that it would suppress the reproduction of those red blood cells because her bone marrow is making too many. And she tried that, and oh my gosh, she was so sick. And now she's decided she's not going to do that anymore. She said the cure was worse than the curse, and she just is allowing them to bloodlet her. But I can tell just from the posts she makes in Facebook that she is not thinking and speaking as she once did. But just think about it. If you've got too many red blood cells, they are coursing through your body, going through every organ. Every vessel is full of these blood cells. So it's really been tough on her. And you'll see on here there's secondary polycythemia. Well, secondary polycythemia is something I experienced when I went to Montana. You have to acclimate when you go to a higher elevation, and that just means that your blood cells have to adjust to the atmosphere you're at. If there's not enough oxygen, you need more red blood cells. And, at first you feel like you can't breathe. You feel like you can't catch your breath, that you don't have. And you don't have enough red blood cells. Well, after a while, that all normalizes and you're okay. Well, once I went up a mountain, we were supposed to go, when you're in the Air Force, you always got a host family. And I was hanging out with them, and they said, let's go ride the ski lifts. So we're going up this mountain. They're not affected at all. Now, mind you, they've always been Montanans, I think is what you call them. But the higher he went, the sicker I got. I couldn't figure out what the heck was the matter with me. My head was pounding, and I was nauseated. I thought I was going to vomit. It was terrible. And it was because we were ascending too quick for me, and I was having secondary polycythemia. So it's an increase in red blood cells that occurs in a person it occurs in response. I'm so sorry. Let me get closer so I can read this. Increase in red blood cells that occurs in a response to prolonged hypoxia and increased erythropoietin secretion. So examples are high altitudes, like I told you. Heavy smoking can do this. I think about the times when I was younger and going out to the bars. You know how it is, or maybe you don't, and I hope you don't think less of me, but I had my share of being a young, silly girl, and I smoked then, and you'd drink beer, and you'd smoke, and you'd smoke, and you'd smoke, and you'd smoke, and that's why part of the reason why you felt so crappy the next day, because of all that vasoconstriction and all that nicotine. But anyway, it also made me have more carbon monoxide in my bloodstream than oxygen. I think it's monoxide. I can't ever remember if it's monoxide or dioxide that's in cigarette smoke. But anyway, it displaced my oxygens, what I'm trying to spit out there. And if a person is a heavy smoker, like, 4 or 5 packs a day, they could run the risk of the secondary polycythemia. And if you took their blood, they probably have more red blood cells than they normally should for their age. COPD, think about that. When you can't, your lungs are already destroyed. When I say destroyed, I mean, if you have emphysema, the alveoli are damaged. If you have chronic bronchitis, then your bronchioles are full of thick mucus, and that keeps you from having a good, proper gas exchange. And that's hypoxia, which would then lead your body to make more red blood cells so that you could get oxygen throughout. So you can see how that works. It says cyanotic heart disease. If your heart's not able to pump correctly and get that blood through, you might have more red blood cells because of that. So secondary polycythemia is a temporary response until the body acclimates. Inappropriate secondary polycythemia means, of course you shouldn't have it. Occurs when the body responds to inappropriate stimulus such as kidney disease or the COPD that I told you. If you have problems with erythropoietin or tumors, either response, the white blood cell count stays normal in secondary polycythemia. So here's the pathophysiology and the etiology of this. There's a marked increase in erythrocytes, like we said, and is often in granulocytes and thrombocytes. So an increase in all the cells often. Now, not with the secondary polycythemia. Remember, the white blood cells stay the same. Blood vessels become distended and blood flow is sluggish and the blood becomes viscous. You have frequent thrombocytes. What did that say? Let me read that back again. It says frequent thrombosis. Dang. And infractions can occur. So, see, my friend Carolyn had a stroke. She did. She had a stroke. So this can lead to elevated blood pressure and heart hypertrophy. Oh, sorry, I'm jumping way ahead here. Results in increased blood volume and viscosity. We talked about that. Blood vessels become distended. Blood flow is sluggish. Frequent thrombosis and infarctions occur. And that leads to elevated blood pressure and heart hypertrophy. Hemorrhages can occur. Your spleen and liver become congested with those red blood cells. And they enlarge. Bone marrow is hypercellular, meaning it's working way faster than it's supposed to. Bone marrow may eventually become fibrotic, which results in anemia. When it's fibrotic, it can't do anything. You may develop into acute myoblastic leukemia. So this right here shows this. I'm jumping over here to the Polycythemia Vera, the JAK2 gene. I can't remember if Carolyn says she has that. I can't remember if she's had that test. Seems to me like she does. But like I said, nobody else in her family has ever had this. And the question is, would it have flared up if she'd never gone to that high altitude? I don't know. So clinical manifestations of polycythemia. Primary polycythemia, which is Polycythemia Vera, all blood cells are increased. Secondary polycythemia, which is usually due to acclimation or diseases like COPD, only the red blood cells are increased, not the white blood cells. The spleen enlarges, we just talked about that, from overworking and being filled with red blood cells. So splenomegaly is a hallmark sign of polycythemia, enlarged spleen. Pruritus, there's an intense itching due to the dilated blood vessels and the poor perfusion. So for these guys, we teach them that they can't really take a hot bath anymore, a hot shower. It's supposed to be tepid to keep that itching down. Increased risk for hemorrhage due to abnormal platelets and abnormal clotting. They have nosebleeds, bleeding gums, and I remember Carolyn talking about going to brush your teeth and it looked like there was a murder and happened in the bathroom. Increased uric acid, lovely. So now they're going to have, what do you have with uric acid? Gout. So now they're at increased risk for gout, which I've never had gout. My son has had it, and I read once before he got it. And this is how I knew he wouldn't, it's because, how kids are or something. Actually, he was a young man. He was probably 18, I think, when he got this. And anyway, I had it read before he ever said anything that gout hurts so bad that a person can't even stand to have a sheet on their toe. And by golly, that happened to him. When he said, "Oh, Mom, man, something's wrong." His toe was huge, red, hot. And he was like, "What's going on? What's going on, Mom?" And he was showing it to me, and I put the sheet on his toe and pulled it on, and of course he's like, "Stop!" So it's true. You can't even stand a bed sheet on it. It's not funny, really. Increased turnover of red blood cells and equals increased uric acid production. So thrombosis, you can have a thrombose. You can have thrombosis, which could cause a pulmonary embolism. Remember, that's a blood clot that hits the lungs. A heart attack, a stroke. And any of those are the most common cause of death in these people. So the diagnostics, we do a CBC, we do an erythrocyte. I thought it was an ESR. An ESR. I think I've misprinted that, but that's where you check to see the level. So erythrocyte sedimentation rate, I did have it wrong. It's ESR test. And that just measures how quickly red blood cells and whole blood descend over a period of an hour. How quickly do they descend? And that's called the SED rate, sedimentation rate. And that can be high when you've got inflammation. So we check that. There'll be an increased, it should be high, this says, there'll be an increased hemoglobin, of course, and increased hematocrit. Wow, look at this. This says in women, your hematocrit would be over 48%. Woo! And in men, over 52% for your hematocrit. Wow. So here's our assessment. We've got lots of things to look at. And then this little video down here is just a guy who's being bloodlet, in case you're curious about it. There's some nursing bloopers, and then they try to correct it because they see they're being filmed, but it's like, come on now, nurses. So your skin is ruddy in color, which makes sense. Got all those red blood cells in there, and the vessels are dilated. And mucous membranes are dry. Lungs, you can be short of breath, especially when you lay flat. Feelings of fullness, left upper quadrant organ congestion, which is your spleen. Your spleen helps your body fight infection and filter unwanted materials such as old or damaged blood cells, and the increased number of blood cells caused by Polycythemia Vera makes your spleen work harder than normal. Because remember, that's long term. The other secondary polycythemia Vera, secondary polycythemia will correct itself. So it's the Vera that's causing the problems. Weekly therapeutic phlebotomy, bloodletting, about 500 milliliters. They may feel immediate relief. I've got to tell you, my friend Carolyn always says she feels immediate relief due to the decreased congestion in the spleen and the liver. If it's done too often, it can actually cause iron deficiency anemia. They don't usually do that, though, not unless it be some sort of emergent reason. Increased fluid intake helps to decrease the hyperviscosity of the blood. That makes sense. We talked about fluid and electrolytes, so if her blood is thick and she drinks more fluid, that will dilute that blood to some extent. You know, that works for all kinds of things. Even hyperglycemia. When you have hyperglycemia, they always tell you, if you've got a high blood sugar, drink, get some water in there because that will dilute the glucose. Hydroxyurea decreases thrombotic complications, and interferon increases destruction of red blood cells and decreases the pruritus or the itching. So chemo and radiation can suppress white blood cells and platelets in the bone marrow. Aggressive chemo is no longer recommended due to the increased risk for leukemia. I have, pegylated interferon is a class of medication that includes 3 different drugs, and as of 2012 suppresses all cell production. They elevate their extremities to decrease DVT risk, avoid aspirin with a history if they have a history of bleeding, minimize alcohol consumption to decrease the risk of bleeding, limit bath time. As I told you, heat causes vasodilation, allowing more blood to come to the surface. So limit your bath time to decrease itching. Use tepid water if you can stand it, mild soaps and lotions, cotton clothes. Yes, and I told you what the itching was due to. Thrombocytopenia is a bleeding disorder. Remember, thrombocyte is a platelet, penia is less than. So, thrombocytopenia occurs as a result of decreased production of the platelets by the bone marrow or an increase of platelet destruction. Antibodies that increase platelet destruction may be genetic, acquired, or medication-induced. Hemorrhagic conditions such as idiopathic thrombocytopenia purpura, ITP, hemophilia, disseminated intravascular coagulation, which is called abbreviated DIC, present with thrombocytopenia, and you can also have heparin-induced thrombocytopenia. Hemophilia is a hereditary disorder, and it's carried by females on the X chromosome, and you'll learn more about that when you get in peds. Epidemiology. Women 20 to 50 are most common to have this after a viral infection and with other autoimmune disorders. Idiopathic thrombocytopenia is an autoimmune response. The body makes antibodies against the surface of its own platelets. Then macrophages come in and they destroy those platelets. Most of those come from the spleen. Usually follows a viral infection or an immunization for children. TTP is a clotting disorder caused by clumping of platelets in various small endothelial cell vessels like capillaries, taking out circulating platelets. And when a trauma occurs, there isn't enough platelets to go to the damaged area to begin the clotting cascade. These clumped up areas cause tissues to become ischemic, and that leads to kidney failure, heart attack, and stroke. Untreated disorder can be fatal in 3 months. Ooh. And then the HIT was a heparin-induced thrombocytopenia, immunity-mediated drug reaction. So it's a reaction to heparin drug. You'll have an unexplained drop in platelet counts after starting the heparin. That's your big indicator. They're not reacting well to this heparin. Heparin has the opposite therapeutic effect then. So instead of decreasing clotting, it increases clotting because of this reaction. And then, of course, we said hemophilia, hereditary lack of coagulation factors, most often factor 8. Disseminated intravascular coagulation, abnormal clumping of thickened blood cells, blood clots from inside blood vessels. I think that's all I'm going to say on all that. I do have idiopathic thrombocytopenia. Purpura usually follows a viral infection. I already said that. Looks like that's a big repeat of everything I already said. Okay. And then you've got your slide that's pretty much tells you all that too. How do we test for this? Our tests are looking for antibodies and low platelet counts. So we do a series of tests. We do our CBC because there's a platelet count on that. They can do bone marrow tests. They'll find increased megakaryocytes in the bone marrow, a detection of antiplatelet antibodies in the blood as if the body's turned against itself, blood smears, a CMP, and then liver function test. So our assessment. We'll monitor vital signs, but keep in mind if the platelet count is less than 50,000, use a manual blood pressure cuff to decrease the chances of bruising. Because you can control how high you pump up, where you know those machines, if you've ever used them on yourself, dang, they can really hurt you. Assess the skin and mucous membranes for petechiae, and that arm is a good, now don't get those mixed up with hemangiomas, you guys already know all that. Petechiae are little blood verse, little capillaries that are bursting, where hemangiomas are just those red dots. And if they're hereditary, and usually everybody in the family's got them. I got them all over me. But they often look like petechiae. And purpura is just bruising. Look for in the urine and the stool for signs of bleeding, level of consciousness, and ask what types of medicines they might be taking. Medical and nursing management. Treatment of idiopathic thrombocytopenia depends on the level of thrombocytopenia present. If the thrombocytopenia becomes more profound, treatment with glucocorticoids has proven to be beneficial. Risk of hemorrhage is the major complication of any condition that results in thrombocytopenia, and the severity of the thrombocytopenia determines whether there is a risk of spontaneous bleeding. Although initial clinical manifestations of thrombocytopenia are ecchymosis and petechiae, as the platelet count decreases, normal activities such as even brushing your teeth or sneezing may produce spontaneous bleeding because you don't have any platelets. Nursing management. If patient has invasive procedure done, such as a bone marrow aspiration, the nurse needs to hold pressure for quite a while longer. I bet so, probably 15-20 minutes. And if you've ever had to hold pressure on a person when they've had a heart cath or something like that, dang, that's hard. I think they've got a lot of devices now that kind of take care of that, so you don't have to do that. And that's it, folks. It is the end. So we've got another PowerPoint down. Please let me know if you have any questions, and thank you.